Welcome to Concussion Nerds, the Roundtable, where each week you'll be joined by myself and 3 other professionals who work in the space of concussion. This is where real cases meet real clinicians. No scripts, no silos, just a group of passionate minds coming together to unpack one person's story, sharing what we see, how we think, and why it matters. Welcome to the Roundtable. Welcome to the Roundtable. I'm so excited you are here. This is a space where we are all coming together to share mind, to collaborate, to broaden the conversation of concussion. This is episode 1, season 1, and I'm Natasha Wilch. I'm a registered physical therapist, and concussion is what I do. I own Symphony Brain Performance in Nanaimo, British Columbia, where we welcome people from around the world who have plateaued, seen 40+ providers, and are stuck help get their lives back with our concussion programs. This space needs more awareness. We need education, we need conversations, we need to start looking at people as people again and not a diagnosis. And so this episode is meant to do exactly that. You're going to be joined by myself and these 3 amazing professionals for this entire season, so let's get to know who's here. Dr. Rachel Parker, chiropractor with a practice of functional neurology with the Symphony Brain Performance team. Can you share more about who you are and what your role is when you're working in the concussion world?
Yeah, for sure. So, like Natasha said, I went to chiropractic school down in the States, and I went to chiropractic school with the intention of treating concussion. And so kind of right along the start there, I started taking courses in functional neurology, vestibular function, concussion, etc. And now I get to practice at a clinic where 95% of what we see is concussion-based and mostly in persistent concussion cases, and get to help them return to life, return to sport, whatever the case may be.
What is it about working with concussion that fills your cup?
Yeah, so I grew up playing a lot of competitive sports, and I got to see both sides of it, where sometimes care wasn't accessible or the education wasn't there, and then on top of that, the pressures of sports and the pressure of performance and the pressure of wanting to win. And I just saw, whether it was from myself or other teammates around me, where they should not have been put back on that field, and whether that's coming from the coaching staff, from the players, the whole kind of environment there, and it led to people who would be passing out on the field unconscious because they shouldn't have been in the game, or they weren't given the right guidance, or it just wasn't talked about enough. And I think that really motivated me to take a career where we can increase the education, the knowledge, and really help people get back to sport or life in a healthier way. And I think that we need more people talking about it, because you need your brain for the rest of your life. It's not just one game, one tournament, right? So that's what really fills my cup, is making it so that other people down the line don't have to go through that same experience.
I love that. Thank you. Next, I want to introduce you to a friend of mine, Dr. McCrodan. He is the owner, founder of Optimization clinics both in Nanaimo and Victoria. And he has a love of working with neuro, concussion, multiple diagnoses. However, we work specifically a ton with concussion and the impacts of vision on concussion on vision. Cam, can you introduce yourself, please?
So I'm Cam McCrodan. I was in engineering before optometry, so we take a little bit of a different approach to the visual side of things, really looking at how the eyes and brain work together, and as it pertains to concussion. So vision is often one of the most misunderstood things after concussion. We're focusing on, is it clear or not, and is the eye healthy or not? And a lot of the times it gets missed for how do the eyes track, how do they work together, how does that play into everything from depth perception and vertigo and imbalance to issues with screen time, reading, tolerance of other visual stimulus. So my passion lies in that area, and I've had family members who've been personally impacted by these things and had it really disrupt their lives because it wasn't properly diagnosed and treated. So we bring a bit of a different lens to that side of vision, and I'm looking forward to being able to share it.
Awesome. And last but not least, Dr. Rob Trachter. Thank you for being here. Robbie is an emergency room physician and trauma physician, and I'm stoked to have you as part of this expert panel for this season. Can you give a little introduction to who you are and how you feel like your role plays into the concussion space?
Yeah, thanks for having me. Like you said, my name's Rob Trachter. I'm an emergency and trauma physician. I'm the only one out of the four of us that doesn't specialize in concussion. So I'm looking forward to learning a lot from you guys as well throughout this season. So my background is I trained as an emergency specialist in Australia, and my fellowship is in pre-hospital and retrieval medicine. Of that, a lot of it is trauma, but more kind of acute trauma. And over the last several years, I've gotten more involved in longitudinal trauma care through the trauma services that have been set up here. And yeah, so I guess my role in treating concussion is recognition mostly, and then sending it to you guys to fix them.
Yeah, no, thank you. And I hate to say it, but like you serve one of the most important roles in this place, because yes, we all do the rehab, but unless the client is aware that they have a concussion and they have that diagnosis and they know who to see, then it's such a delay for them to get to us to do the work. So in my opinion, as that trauma physician, as that emergency physician, you're such the pivotal first point that you set the course. No pressure.
Which is challenging. which is challenging because we probably know the least about managing concussions, right? So
yeah. You know, it's so I just got to give this talk at a trauma conference, and it was to a room full of trauma physicians. The energy in this conference was amazing, but it's trauma physicians and nurses, and I asked the room because we know. You're going to learn if you didn't know before this, that there's 7 profiles of concussion, right? And so I just asked the room, I was like, just out of curiosity, does anyone know that 7 profiles existed? And it was crickets. Not a single hand went up. And I said to them, I was like, that's okay. Like, that really is okay. Because the symptoms of those 7 profiles overlap so much that the key, and like you said, your primary role is that recognition. It's the recognition, identification, a diagnosis, and referral. And if we can have more emergency physicians as passionate about understanding that as you are, then so many more people are going to get care faster. And so I love that, you're going to learn some cool things from us just from the rehab perspective. But I wanted you here, and I wanted you part of this because you do play a pivotal role in someone's concussion recovery. When you pull up the stats, more and more the studies are showing that if you can have somebody referred to a concussion-specific clinic within the first 7 days, it expedites their recovery, right? And like Rachel, how many times do you hear of people coming into the clinic that, like, it's better now because we're doing, but like on average, how many times do you hear of people coming into the clinic that it's been weeks or months since their concussion and this is their first point of entry?
That's the vast majority, honestly. And I agree. It does, like, a lot of people do go to the hospital or urgent care or somewhere like that first, and it's all about kind of that luck of who they see and if they're given that referral and if they're kind of told that guidance of where to go next, right? Because if they're not given that, then how are they supposed to know?
Yeah. And I feel like you guys get a bad rap, to be honest. You know, I think people don't recognize, and because we are friends as well, and as I was preparing for this presentation, Rob is the only emergency physician I know, and so I was texting him questions as I'm preparing this presentation to be like, how much, because my whole point on that presentation was identify and refer, that's it. But then my question was, how long do you get with a patient in Emerge when they come in? And like, what did you tell me?
It's pretty variable, and it depends on the situation. Obviously, like if it's a major trauma patient, then we may end up spending 2 or 3 hours with them in the emergency department and resuscitating them, treating their myriad of injuries. But if someone comes through ambulatory with I stood up and knocked my head on a counter, you might see them for 2 or 3 minutes. So it's pretty variable, and there's it can be fairly brief, and it's the focus is on ruling out the emergent time-sensitive diagnoses, and yeah, some of the other stuff often kind of falls by the wayside a little bit.
Yeah, and it's that piece of, so when I'm trying, I remember trying to be like, well, I can't teach you to do a VOMS. I can't teach you to do a full screen. So what can I tell you to help identify concussion in the emergency department? And so, but again, like when we had that conversation, I was just like, I think people also need to remember the purpose of an emergency department, right? And you just said it, it's to rule out the serious kind of medical conditions. And so, you know, as someone who's an emerg and a trauma physician, when you rule that piece out, how easy is it for you to then kind of think about the domino of like the milder pieces?
It's very variable depending on the condition and the practitioner, and it's one of those things that oftentimes, like, one, you don't know what you don't know, but also if you don't think about it, then it gets forgotten. So our job is to prevent mortality, but also morbidity, and something like this has a lot of downstream morbidity. But the problem is that when we're seeing the person when the incident happened 2 hours ago, you have no way of knowing who's going to be affected by it 6 months from now. And that goes with more than just concussion. So yeah, sending them to just at least highlighting it and flagging it and sending them to someone who can follow them up longitudinally, because if all goes according to plan, we'll never see that patient again, right?
Right, fingers crossed.
Yeah.
I always find, you guys know when you're like planning educational material or you're reading, when you're looking at something, it's all of a sudden like all these studies show up in front of you and you're like, oh, like the universe has my back. And when I was preparing for this conference, don't ask me how, but this study showed up in front of me. It was a level 1 trauma center study. I don't even know what that means. PS, by the way, but okay, sweet. Level 1 trauma center in the US, this study was done, and they were looking at concussion in this trauma center. And I was like, how coincidental that I'm prepping for a trauma conference. And they found, hold on, I wrote this down because I knew I wouldn't remember the stat. 1 second. Oh my God. Okay, here's what it was. 62% of individuals that were diagnosed with concussion and emerge said they weren't interested in receiving follow-up care. 92% of those people felt like they didn't need it, which I feel like from what the three of us say all the time, we need more education and awareness, because everyone should be assessed, in my opinion. But of that 62% of the not interested group, 42% ended up getting care, but 44% of those individuals at 2 weeks had incomplete recovery. 40% of those went on to develop persistent concussion, and 19% of those continued to have decreased quality of life at 6 months. And so and so their summary was that, you know, the EDs need increased education awareness, which who gives that? Who knows, right? It comes back to the systems and the flows of things. But when you look at the leading causes of concussions being major falls and MVAs and workplace-related injuries, like everyone thinks of sport, but sport is not the most actual prevalent reason people get concussion. The ED and physicians are that first kind of line of defense a lot. Sorry, I tangented on that way more than I meant to, but I think it's super important. Okay, I want to do a little concussion speed round. So what I did, so just for those watching, what we're going to do here is I Googled, or I asked, supportive AI. I said, what are the most Googled questions when it comes to concussion? So we're going to do a little 4-question speed round here, and then we're actually going to start to dive into a client case. And you're going to hear some thought processes from us, and we're going to share a client case and go from there. So the 4 most Googled questions, according to ChatGPT. Number 1, how do you diagnose a concussion? I'm going to pass that one to you.
So we diagnose concussion, and I think it's actually hard to diagnose concussion in the emergency department because it takes a little bit of time to make the diagnosis. So I think that one of the things that I've done, instead of saying you have a concussion, is you probably have a concussion, or you might develop symptoms of a concussion. So essentially, concussion is a minor head injury, and a minor head injury in terms of the definition on the grand scheme of things. So no neurosurgical emergencies or anything like that. Previously, I've thought of it with normal brain imaging, but we do treat people with minor, more severe traumatic brain injuries, little bits of blood as concussion, but essentially it's a minor head injury with persistent symptoms such as headache, nausea, poor concentration, mood disturbance, and I'm sure we'll get into more of the symptoms down the line. But yeah, so that's how I think of concussion, and it's interesting because it's seeming like my previous beliefs on what it took to get a concussion is not actually true, and I think that it's the minor can be pretty emphasized, and it can be a pretty minor incident that people come in with persistent symptoms, or it can be a pretty major mechanism and people have no symptoms. So it's yeah, probably a lot more complex than I understand, but that's how I think of concussion in the patients that I see.
Awesome. And so I always like to throw this part in there. We don't use imaging to diagnose concussion. So so a lot of times people are like, I went to the doctor and I have these symptoms and I went to emerge and they didn't even order imaging. What would prompt you to order imaging?
So we order imaging on patients that we suspect blood or fractures. So things that are going to change management or change prognosis. So skull fractures, other types of blood. You can categorize it into a number of different diagnoses, but basically something that we think is going to change their outcome or change how we manage them. Like, do I need to send this person to a neurosurgeon, or do I need to admit them for repeat imaging or neuroobs and those sorts of things? So if we don't think you have any of those, then imaging is just going to be unnecessary radiation. It's not going to change how we manage you, and it's not going to change your outcome. So it's not worth the risk. Cool.
This is why I love this format, because as you talk, I have more questions. Because you said something that I think is actually really important when it comes to client case management. So you've said, I think you might have a concussion. If you do, if these symptoms persist and you refer them to a clinic or whatever, do you recommend people go to the GP, and does the GP have access to that piece? Because what happens, especially if it's an insurance-based claim, none of us are allowed to diagnose concussion. So that diagnosis needs to be on a medical chart from a physician. So I can absolutely appreciate what you're saying, but then are they guided to a general practitioner if they're still doing that, and a clinic?
So if I think someone has symptoms that are consistent with concussion and a mechanism, then what I will do is I will say highly likely or probable, I will give them a referral to either our local concussion clinic or to someone like you, and say, if you wake up in 24 hours and 48 hours and feel completely back to normal, you probably don't need to follow through on this, but even if you go see them once and they say, yeah, you're fine, you don't have any ongoing concerns or symptoms, that's better than it dragging out down the other end and having persistent symptoms and not seeking care. So I have a pretty low threshold to refer, and if they don't need it, they don't need it.
I think that speaks for us, in our field too, of then, again, this is why I love conversations. That piece is, if we get that new referral, making sure that they are also still following up with their general practitioner, and we're sending a summary note or something to say, continuing to show signs of concussion, and getting that from a GP on their medical record as well to support. We all know that, especially US, Canada, dealing with insurance can be an absolute fucking nightmare. And so thinking of continuity and patient flow and trying to set that patient up for success, whether this is going to be 2 weeks or however long, right? Thank you. Next most Googled question, Dr. Rachel, how long is my concussion going to last?
That's the golden ticket question, isn't it? Yeah, and it's hard because I think a lot of people think that if they just have a minor knock or a small fall or something, that their symptoms will resolve really quickly, and if it's bigger, that'll correlate to a longer recovery time, which we know isn't necessarily true, right? And so that ability to predict how long someone's symptoms might persist is really difficult. I think there's certain factors like we talked about in terms of how quickly they come in to see a concussion literate provider that go a long way in terms of somebody's trajectory of recovery. But in terms of predicting how long exactly are your symptoms going to last, I think that's a very gray question.
Yeah.
Gray area.
When you pull out the stats, although we know most stats are on sport-related concussion, what is the average timeline, an adult? Because kids and adults different. What is the average timeline to start to see symptom resolution for
an acute concussion?
An acute concussion.
Within those kind of 14 days, so that within those 2 weeks. But the predictability of whether that acute concussion is going to turn into persistent symptoms, I think it's hard to tell at the initial onset.
There was a new study that just came out that actually was one of the first studies I've read that looked at the general population. Because the old statistic, and I'm going to squash it right now because I hate this stat, that says that 80% of individuals will recover within the first 2 weeks, right? That stat is on sport, men. And so there was a new study that came out. I can't remember where it came out of now. I literally just read it last week. Again, coincidental studies showing up in my inbox. That looked at the general population and says that, for 50% of people, 4 to 12 weeks of the general pop is what they found in this group as an average timeline of recovery to be back to functional recovery. So.
Yeah, which I would say is much more common than, I wouldn't say a majority of people that come through our door are better within 2 weeks, right? So I think that kind of aligns better with what we see clinically.
Yeah. And like you said too, the mechanism matters. Sport, and you probably see this with just vision, sport recovers faster than MVA, assault, workplace injuries, always, almost, I would say. Or that's clinically what we see in the clinic anyways. Most Googled question number 3, take this one. Can someone sleep after they've had a concussion? Please don't wake someone up every 2 hours. So, right? Sleep is our friend. Now that being said, we do want to keep people awake for the first 4 to 6 hours after they have a concussion, because if someone's going to develop those red flags, right? So our red flags being increasing neck pain, headaches, dizziness, loss of consciousness, slurred speech, memory issues. I feel like I'm forgetting seizures. I feel like I'm forgetting something, but those are going to develop within the first 4 to 6 hours. Those red flags, what that means is we're worried about a more serious injury. You're going to go to Emerge, you're going to see Dr. Rob, and he's going to run some imaging. But after those 4 to 6 hours, if nothing is progressed, or you've gone to Emerge and you've been cleared of something more serious, please let the individual sleep. We do not need to wake someone up every 2 hours anymore. And most Googled question number 4, Cam, this one's for you. What are some of the long-term consequences of concussion?
Coming from the visual world, some of the long-term consequences we see, a lot of it has to do with binocular vision dysfunction, similar issues where the eyes have trouble working together, they have trouble tracking. So those are the people where they're facing limits in their computer time, they're having a harder time focusing, concentrating. Vision can be a trigger for headache and migraine and dizziness. And those are the kind of visual issues that often don't sort of self-resolve within that time period. And I think one of the other things that you face is we live in a digital modern age now too. There's a lot of unnatural strain on our visual system that the human body's not really made for. So a lot of those people are way more sensitive to that after the fact. So that's where visually we see a lot of long-term implication with people where they just kind of can't get back to that stuff.
Yeah, and I would say our vision's always a piece. Of our persistent clients, vision is always a component of.
I think statistically it's 70% of our incoming sensory information is visual. It's almost half of our brain is involved in processing vision in some manner or form, right. Whether it's in the sensory processing or the motor components of things, how we deal with depth and space. And so, yeah, usually for us, it's we're seeing the people where vision hasn't appropriately been dealt with. So I have to say my clinical population kind of self-selects that way. Usually they come in because they have problems.
Valid point.
Although, we also do a lot of regular eye care too, but bring that same kind of lens to it. So we're also seeing the population who aren't concussed, and we can see and measure some of those things too.
What I love about that, and this is a future episode at some point to talk about, is that's speaking into the topic of performance and optimization. Your clinic name, Symphony Brain Performance, optimization. There might be a reason we chose our company names the way we did, right? Because I think everyone here would fall in, I'm assuming everyone here falls into the same thought process as me, is we don't always need to be reactive, we can be proactive in terms of brain health, right? And when we can see things either from a visual assessment or from our multi-systems assessment that we could improve in somebody's brain function, A, they're gonna be able to perform better in life as a whole, and B, I believe it's gonna put them at potential decreased risk of severity of injury should they get a knock to the head or whatever down the road. Yeah. Okay.
There was, on that note, interestingly enough, there was a study, I believe it was University of Cincinnati, somebody will probably fact check me on this, but I believe it was University of Cincinnati, and they found that their football team, the football team that received a fair bit of visual training stuff, that portion of the team had less concussions over the season.
That is one of my friends who led that study.
Oh, was it?
You are
Okay.
100% correct.
Yeah.
And he worked with the football team and I believe soccer and baseball on that. But they did pre-season camp, huge neurovisual piece of it, and 100% they got their concussions down.
One of the things we watch with our patients too is actually the people who we've treated for visual issues, when they get re-injured, the visual stuff is nowhere as severe as it is when we first seen them, or when we see people where it hasn't. And often the patients are surprised. They're like, I really thought I would have more visual problems after this latest concussion. And they're like, but it didn't seem to be as big of a problem.
Yeah, I think of it as anything, right? Like the brain you bring into the situation matters, right? The body we bring into a situation matters. So
yeah, I was sorry to interrupt. It's like you get me all excited about that piece because I don't know about you guys, and this is actually a question for you guys too, but some of the people I see who do the worst visually after concussion are people with a history of dyslexia, attention deficit, sort of headache and migraine, and sometimes things that actually indicate that they had some level of binocular vision dysfunction or other visual issues prior to the concussion, and then post-concussion, those people seem to be some of the ones I see that like do the worst. So like it's an already fragile system that's just been made worse.
Absolutely, yeah, and it's why I'm like, we don't go see Rob every year for physicals and checkups, but we see our general, Rob's like, no.
I would have a really bad job.
But we see we probably don't, but like we see our physicians for physicals and like health physicals every year. I am still like, why aren't we seeing our functional optometry and our physical therapists and our chiropractors every year for that same thing? Because again, the brain or the body you bring into a situation is gonna impact, I think, how you respond in that situation. You see it, we see it all the time too. We'll talk about it in a different episode, but how trauma layers into that. And like a super dysregulated nervous system coming into a concussion, like all these things 100% matter. Okay, I do want to introduce us to a person. 1 second. Here we go. Part of what we do here on the Roundtable is we have real people who have connected with me who want to share their story. And they want to share their story because they've been inspired by someone who, hearing something similar to what they were going through, A, gave them hope, and B, helped them chart a path forward for themselves. The other piece of it is everyone here practices in a mindset of integrative care, holistic care, and I'm trying to say this nicely. We just get fed up with hearing the shit stories and the crappy care that exists in this space.
Oh, that was the nice way?
That was nice.
Okay.
that was my checking my tongue. nice way. Holding back. And so what we want to do, and all these amazing humans, you're going to hear 4 different stories over the course of this season, have shared their story with us so that we can, A, talk about the trajectory of care, but also these people are all a little stuck and are also looking for insight. And so while it's a little bit tricky when we can't use our tools to physically assess them, we know when people say certain things or have implications, we can share thoughts and insights about it. And so that's what this is for. So I'm going to introduce Jasmine to the world today. Jasmine is 35 years old. And so she experienced a concussion via a car accident in January of 2023. Now, I've had the pleasure of working with Jasmine in the past, and in the beginning, I'm just going to share this too, for those of you who are listening who are feeling like you're a bit defeated. When I first met Jasmine in April of 2024, she shared that this concussion has negatively impacted my life in so many ways. I've had to postpone my master's degree. Symptoms have plateaued. Rehab is no longer helping. I am beyond frustrated and simply want to start feeling like myself again. Jasmine actually came to Symphony for an intensive, which was kind of the kickstart to her getting progress again. So just again, to go on that piece of hope, and that there is never a dead end, and sometimes we just need to find the right people, which is why I'm so excited to dig into this with you guys. Today, Jasmine is going to concerts without earplugs. The loops are in her pocket, but she doesn't need them. She's joined a hiking group. She was able to travel. So Jasmine used to travel all the time. And when she got her concussion, she wasn't able to. And in this past year, she's been able to travel to India, to Montreal, and enjoy, this is an important part, enjoy the experience. She is navigating crowds easier, and this one almost, okay, Rob, you might not know this, these guys do. I cry all the time when I hear client wins. This is just, I happy dance and I cry. And Jasmine shared with me when we were doing this interview, she was like, I'm able to feel joy and just laugh naturally again. And I think sometimes for those of us that aren't on a persistent journey, we can't fully recognize what the loss of those little things mean to living a happy life, right? All right, back to the things. Initially, when Jasmine first came to see us, she was experiencing headaches, vision challenges, inability to focus, trouble with memory, information recall, feels like everything is always moving, plus true bouts of vertigo, nausea, brain fog, tinnitus, the inability to regulate emotions. She was having panic attacks, sleep challenges. She also still had diagnosed, obviously, whiplash, pain and stiffness in her neck. She started having vasovagal syncope, which led to a decline in her mental health. And this is when the panic attacks started, as well as nocturnal panic attacks. She struggles more with regular anxiety attacks now, and depression due to the concussion symptoms, which are so overwhelming to handle. The concussion has negatively impacted my life, as I talked about. So this was when I first met her. She's a single woman. She lives with her parents, 2 siblings, in a multi-generational home. She provides support to family members also facing health challenges. And one of her family members was not too long ago diagnosed with their own neurodegenerative condition. She has another family member who struggles with mobility and general health as a whole. And Jasmine's also had to navigate emotional impact of supporting multiple family members with substance abuse and other medical issues. So these at one point, while this under control, would have been a huge factor and stressor in her own recovery. And so when we're looking at that persistent piece, it's that importance of we look at the whole person, right? Past medical history, she is PCOS, polycystic, oh my gosh. Please.
Just say PCOS. Polycystic ovary syndrome.
Okay, what is that?
It is a condition where you develop cysts on your ovaries, but is associated with hormonal imbalances and pain and yeah.
Okay. She is suspected endometriosis, celiac, and Hashimoto's, thyroiditis. Also has eczema, has struggled with gut issues like leaky gut, has a mild factor 7 deficient, I don't even know what that means, mild factor 7 deficiency.
Clotting.
Okay.
Clotting problem.
Thank you. Which results in high NIR levels.
INR, yeah, more bleeding stuff.
I was so glad I just heard him look here. Depression, anxiety, and then exercise-induced asthma, but only in extreme scenarios. So Jasmine's big things is she would really like to be able to return to work. She was doing her master's in holistic nutrition, and she's not really sure what she wants to do or where she can go. She would love to be able to return to academics and reading. This is a huge piece. She would like to be able to return to skating. And right now, she used to, I didn't know this about her until recently, she said she used to write and speak a lot. And she's not doing that right now because her voice just doesn't feel like hers. So she's really struggling from a cognitive lens too. So We're going to talk more about that in a second. Her current challenges. So these are her big key ones. So what I just shared was kind of her pre-existing. She came and had an intensive with us at Symphony. We did a ton of work. She started going to concerts and all these things. She's doing awesome. However, this is what she's still dealing with. Gut issues, so bloating and abdominal distension. Headaches. They are intermittent, increase, and they get worse with visual tasks specifically. Body fatigue, cognitive, mostly, these aren't on your list, mostly left forehead and temple. Dizziness, mostly with exercise demands, and when there's like multiple systems involved or with increased temperature. And balance is still an issue as well. Cognitively, she feels like she can't focus for the life of her. Those are her words. Memory recall. She says that if someone prompts her with something, so she'll be like, yeah, when I went to her, someone might say to her, you remember when we went to the mall and or I told you this thing, and she'll be like, no. And the person will be like, you know, we were blah, blah, blah. And if she gets that prompt, she's able to retrieve that memory. But to just have it on the forefront of her brain, to retrieve that, she is really struggling with that. Heart rate is a big thing. She feels like it's getting too high. And so I asked her what this meant, because she doesn't track her heart rate. And she says, I can feel my heart racing, and it feels like it's going to burst out of my chest, which can't feel too good. And it's very hard to calm it down. So she'll do intervals to spike it intentionally, and then she used to be able to settle it pretty quickly, but it's taking up to 5 minutes right now to settle that heart rate when she tries to do it. Flashing lights really bother her. Strobes, any bright light, she feels really nauseous after. And then her neck, she received prolotherapy, but she's still got some pain in the suboccipitals, lack of strength. But she said her head feels a bit more stable. So one of her other big areas of complaints is her vision. So Jasmine was doing really well, like we talked about. She was doing these concerts, felt like life was on the upswing. And then she started vision therapy. And she said it made everything worse. She said when she's doing a task like reading, there'll be a moment, like she describes it as her eyes just kind of piece out and she can feel them diverge or like move apart. She said she actually feels like she's going cross-eyed and seeing double, but her optometrist said her eyes are actually diverging. Too long on the computer could be 10 minutes to 30 minutes. I feel like that's 30 minutes is, yep. She feels like the task of reading is a little better, but she's got zero comprehension. So she can do it a little bit more, but she's not remembering a thing that she's reading. Driving, when it's fields, it's fine. When she's driving into the city, not so fine. Just lots of the visual stimuli on the sides, so lots of things in her periphery. She was informed by her vision therapist that she wasn't able to converge in the far, and we're talking like 8 feet plus away. I don't know what that means. Cam's gonna explain this stuff to us, because, and when she's tired, things feel even out of focus, even when she's wearing her glasses. And she does, I think, have a prism lens, I think. Emotional and emotional, sorry. She's doing well managing anxiety and panic attacks overall compared to before. But right now what's come up, she said, is a lot of grief with the loss of identity and the loss of time. She's 35, right? So the loss of time in life. So this is Jasmine. She's got a team right now. However, she's got a physical therapist, a chiropractor. She did have a vision therapist. She's no longer working with that person. But Jasmine reached a point about a month ago that you could describe it as rehab burnout. The thought of doing rehab exercises pissed her off. The motivation to do them was non-existent. She was just feeling burnt out. So when we had a conversation, I just told her, I said, take everything off your wall. Take down the Post-it notes, take down the X's, take a break, and then come back to it if you feel ready to in the fall. And so that's where we are. And so I know what Jasmine is kind of hoping for is our thoughts on what we're seeing, and we can talk through these, and then what is that next step for her? When she looks at re-engaging in therapies this September or October, what does that actually look like? So I'm just gonna jump to Cam, because she was doing so good. Like she's on, I see her on Instagram and she's like posting videos of the concert and like she's hiking and she's loving life. And then she starts vision therapy, which so many people get prescribed vision therapy after concussion. And her immediate thing is like, I've lost my capacity, I've gone backwards, and everything has gotten worse. Why? I know that's a loaded question.
No. It's actually, I think it's actually one of the most amazing questions. So to tangent for a quick second, in school, they talk about, and Scott Adams talks about this, the guy, founder of Dilbert, but in school, you're taught to think different ways. And so in engineering, we're taught very much to look at what are the symptoms, what are the problems, what's going on, and then what systems could be responsible for those symptoms, and then looking at are there ways that we can then measure to see which systems are having the issues, and then how can we make them work better? And we kind of went at it from that way. In optometry school, one of the challenges is what we're taught to do is to make the diagnosis, then turn and do what the book says for the diagnosis. And there's often not a lot of thought given to this kind of systems behind that. So that's one thing. Then I'd say second, within the realm of like vision therapy and optometry, there's very different approaches to treatment. And unfortunately, a lot of it, I think, is still stuck in an older model where we're treating visual stuff like it's physical therapy. Like as though this is hard for you, do more of it, it'll get stronger, it'll work better, you'll adapt to it or whatever it is. And we're approaching it through like that lens.
I love that's what you say, because I'm going to come back to that in a minute.
And I mean like that's my understanding, like older school physical therapy.
That's what everyone thinks of as physical therapy.
Entirely. And that is the older approach to it too, is it's like, we'll do more of it, you'll get stronger, you'll get better. And so you look at a case like Jasmine's, and from the engineering standpoint, you go, okay, well, something's not adding up. So what we've found over the last 12 years of our own R&D and various other stuff, oh my goodness, it's like 14 years now, is that the approach to vision therapy really shouldn't be about trying to do more to get better at it, but you're actually using exercises and activities in a way to help the person recalibrate how they're doing it as opposed to just doing more of it. So if you look at a case like Jasmine's, what this immediately tells me is there's a couple of things that are missing, obviously. And so if you take somebody who, for example, if their eyes are doing something in kind of like a bad pattern, it's like having bad posture. So imagine you've got a runner and they've got a bad gait. Well, guess what? More running is not necessarily going to make that person's life better. You need to address their gait. You need to address their movement patterns. You need to do those things. And a lot of people still approach the vision therapy world and still understand that world as though it's the more running. Sorry, you tested badly on this, you can't do this well, so we're going to make you do more and practice it. And you can take people and you can drive their symptoms way up because you may actually just be making them repeat and further cement this poor pattern of visual function that they already have.
Can you give us an example of something that...
One of the most common ones. Okay, so people go, okay, like converging on something, either A, you can't do it, or B, it drives your symptoms, so guess what we're going to do? We're going to give you more converging. Okay, so we're going to send you home with a Brock string, we're going to do whatever. Some of those people, you're actually going to make their case way worse. So for some people, it may help them because somehow they'll figure out how to do it a little bit better. For other people, you're actually just going to drive their symptoms way worse because you may actually be, their problem might be that they actually over-converge in different ways or that they do all these other things, and you might actually be taxing a system that's already not working that well, and you're not teaching that system how to perform it in a better way to begin with. That's like one of the most common ones that's seen, but it goes for so many other different areas of vision. So that's kind of one piece of it is somebody approaching visual therapy like a do more because it's hard, repeat it, it'll get better. And what I'd say to people listening and watching is if whatever activities you're working on within the realm of visual rehab, if those things aren't A, performing better, or B, becoming less symptomatic within the course of like a week or two, chances are you're not working on the right thing and not in the right way. And really the goal of anybody performing high quality vision therapy is about helping that patient use whatever exercise or activity they're doing as essentially like a neurological feedback loop to help their brain understand that it has different ways it can do it and how to engage those things differently and then how to get that performing better. Whereas again, I think a lot of people are still stuck in, here's the activity, do it, just keep repeating doing it instead of using it as a learning experience. So that's kind of one piece is the approach to therapy. The second part that I think is really important to hit on is a lot of people talk about glasses and prism. All right. So, I mean, I'm an optics nerd. I'm like the last person the reps want to come around to see because it's like I can cut right through their marketing. But when we talk about glasses and lenses and other things, there's sort of two fundamental things to understand. One, every lens has quote unquote prism in it. Okay. Any glasses lens will magnify space or minify space, change spatial perception, and it can also even change how the eyes align with each other depending on where you're looking within it. So a lot of the time people will be like, well, I've tried prism. Okay, so what is Prism? Prism is something we can use to kind of balance alignment of the eyes. We can also use it to change spatial perception. So Prism can also change the depth of people's spatial perception. It can change how the eyes and inner ear work together. There's all these different components. So a lot of the time people will be like, well, I've tried Prism, and it's like, well, okay, you tried one provider's idea of using Prism. Okay. Now also the majority.
There's nothing standardized around Prism prescription.
No, there's kind of like approaches to it, but a lot of them are based in kind of like old age, just kind of like this is sort of the rule. And a lot of it's not super functional. There's sort of higher tech companies looking at prescribing Prism stuff, but most people will, so if you have a bit of an eye misalignment, a lot of the ways eye doctors will deal with that is they go, okay, well, we're going to give you like half of your misalignment for your system to do it, or we're going to get it to just where you're not getting double, or other things, instead of looking at how does that person function best, like what amount of Prism or kind of leveling between the things is actually going to have their system functioning at its best level. So there's no sort of standard of care in that area, which is one of the things that drives me nuts. Plus, half of the people listening and watching this are looking through glasses that actually have, like they're looking through Prism because of the way the glasses were made and prescribed, and it wasn't paid attention to. Anyways, there's a whole rabbit hole I could go down there that I do lecture on.
Matt is not passionate about Prism at all.
The amount of patients that I've seen where like that's been their issue, and but nobody's paid attention to it.
Right.
It drives me crazy. So I look at a case like this and I immediately go, no disrespect to a provider, but it's from what I've gathered here, it sounds like we're working on an older school model of vision therapy that's more about just kind of doing and repeating and not ensuring that patient is progressing and learning how to do those things better. Yeah. And B, the other thing I wanted to mention about glasses and lenses is, humans aren't made to live in this environment. Our visual systems, our bodies, we're not made to stare at screens all day. Okay, we're not made to stare at our phones. That level of work is not natural for us. And then especially as we age too. So if you look at our evolution and what our system's designed for, a lot of people post-concussion become more sensitive to some of the unnatural visual demands of our daily life. And a lot of the time that doesn't get addressed either. And so I immediately look at a case like this and I go, has her visual function been properly addressed for while she's reading? Does she have lenses that are supportive for the best quality eye movements? Because zoning out and not remembering when you're reading, a lot of the time that's because your brain has to put too much cognitive power into the motor movements of reading. And I've been there, I experienced that myself. Yeah. Zoning out after 2 pages of reading, being like, I just read that, and you have to go back and reread it. So, those are some things in her case, and for anybody thinking of something similar to this, that'd be my sort of takeaway from it is, are glasses and lenses being properly used to help with symptoms, and especially during some of these functions and tasks? Yeah. Has that been addressed? Has it been addressed in a functional way that actually looks at how her eyes and brain work together with those lenses? And then also approaching vision therapy more from a recalibration sense than a, repeat it.
Cool. I think too, you had like the perfect segue into actually how the multi-system piece factors in and how our professions can work together too, right? It is not by accident for those watching that we have 4 different professions on this show, right? And so you talked about the skew. And so what we do at Symphony is we do a multi-systems assessment. And so we're looking at the somatosensory system, the cervical system, the autonomics, the visual, the vestibular. I feel like I'm forgetting something off the top of my head. And then we refer to you when there's this visual piece. But one skew, for example, while there can be a visual piece too, there can be a huge vestibular component to why someone has that skew deviation. And so this is an example of how our professions can work together, because having a vertical misalignment of the eyes it wreaks havoc with function. And we could use Prism from CAM to help that while we simultaneously rehab the vestibular system to help correct the skew should the vestibular system be, and we have tests to help figure that out, should the vestibular system be one of the drivers to why the vertical skew is there to begin with, because it's not always. And so when we can do that in our assessment to be like, hey, there's a clear vertical skew that we're seeing on assessment, it is resolving with whatever, we know that this is an otolithic piece, but it's gonna take us a little bit of time. Can we support them so that they can function better in the meantime so that we can still do our rehab? And so I love it because it's super cool for the client to see too. So what we do, I don't know if I've ever told you this, is when we get someone that comes in with your glasses, we'll assess them in the test without the glasses so we can see, and then we have them pop their Prism on. or their lenses on, and then we reassess with the lenses so we can also see, okay, sweet, this is, because we don't always have your prescription to know, so then we reassess with it to be like, okay, this is what the glasses are helping correct, so then we can work with this as well.
Can I add one quick thing about Prism too for that? So a lot of people think of Prism as a compensatory thing or as a crutch only, and while yes, it can be used that way, I mean, it's also not really much different than our shoes either. So Prism can also be used in very intentional ways. So for example, you know, Rob sitting there, like your glasses, to make you see clear, they also they have a minification effect, which actually then can create a more unnatural interaction between your eyes and inner ear. And you can use Prism to actually help offset those things too. So I think one of the challenges is, and I've faced this when I've had clients go with other clinics, the second somebody hears Prism, they think that there's something being done that's a crutch or a compensation, and the goal is to get rid of the Prism. When in reality, a lot of the time, like the Prism can actually be a very important factor in making the lens have a more natural effect on their systems than their regular prescription would have otherwise. So I think that's something language-wise that it's like, hopefully if therapists can take that away, Prism isn't necessarily some evil, unnatural crutch, or the goal should not be to get rid of it, because it can be an important component to giving somebody a much more naturally functioning prescription compared to just sort of the regular one, which may inadvertently have negative Prism in it.
Oh, thank you. I just learned some tidbits. Did you learn some things?
Yeah, the whole time.
Like,
I'm like, God,
my brain is
I'm like maybe my glasses need an adjustment.
Oh my gosh. Jasmine, and I said to this for Jasmine too, is as she kind of, I always think when you take a rehab break and you come back to something, you need to get a new baseline. You need to get that piece to figure out where are we starting from to make fresh goals going forward. And I think for Jasmine, and I've had this discussion with her, is this piece of, we need to look at the whole picture, right? We need to look at all the systems so we can see what's working well on its own. I'm going to come back to your physical therapy comment in another episode because, I mean, you've nailed, that's what everyone thinks of with physio. We need to see what's working well on its own, how are they integrating together, and how can we work with this human as a whole person, integrating their systems together as opposed to working in these individual silos that ignore everything else. And so for Jasmine, she is planning to come over and do kind of that reassessment, and I think it might be very smart if I chat with her about actually having her come connect with you from a vision standpoint as well. For those listening, my goal is 30 to 45 minutes. Welcome to episode 1, that's probably 50. Any final words for our watchers?
I don't think so. I think we hit a lot of points there, and I think specifically for Jasmine, I think it's really important what you said about sometimes you just have to take a rehab break, right? And when things have been happening for so long, it can get overwhelming, and that anxiety and that overwhelm, it can just flare our symptoms to different levels as well and different perspectives there. So I'm glad that she's kind of taking a couple months to just live her life and be herself, and then hopefully she can get that reassessed and we can figure out where to go from there.
Well, to everyone watching, thank you for tuning in to episode 1 of the Roundtable, and we'll see you next time.